Good morning, everyone. Welcome to today's lecture. This lecture is organized by the Scientific Committee of the Physical Therapy Department of Ibn Sina Hospital. As a general rule, you will be all muted. You will be only allowed to be unmuted during the question section of the lecture. So please try to mute. We will be keeping you muted, and please stay muted all the time. If any, just the questions, reserve it for the end of the meeting. This Zoom meeting is being recorded, so if you are uncomfortable, just turn off your camera. So today's lecture is about ECMO. Okay, our lecturer today is physical therapist Alaa Alsaeed. She is a specialist physiotherapist who graduated from Kuwait University 2005. She was working in Alaa Hospital. She's specializing in cardiopulmonary, ICU rehabilitation, cardiac rehabilitation, and ECMO. She has presented many lectures about physiotherapy role and intervention in ICU and cardiac rehabilitation. And she has conducted many workshops on early mobilization of patients on ECMO. So please let us all welcome PT Alaa Alsaeed.
Thank you, Carols. Good afternoon, everyone. First of all, I'd like to thank Physiotherapy Department and Ibn Sina Hospital for inviting me today to talk about the role of physiotherapy in ECMO. First of all, my sound is clear to everyone, so I can start. Sorry. Just can you allow me to share my screen? Sorry, I want to share my screen. Is it any option?
Alaa, I allowed already.
Okay. Yes. Okay. So let me first talk about the concept of physiotherapy in ICU and how it changed in the last 10 years. Before, the physiotherapist was focusing on the chest physiotherapy, pulmonary hygiene technique mainly, and cleaning of the airway. But over the last 10 years, the early mobilization became the most important trend in ICU medicine. And it's not new. In 1944, William Duck found that in mobilization or early mobilization improve the general health and strength, and the morale is greatly improved. And also in 1975, in the Department of Thoracic Medicine in Giesinger Medical Center, the concept of early ambulation is clinically useful. It was useful, and they found that by early ambulation, weaning has been facilitated, and the problems of a prolonged bed and chair rest was minimized. The healthcare provider has turned their attention to the physiotherapy nowadays, back again to early mobilization. Physiotherapy has been recommended by scientific societies as a main component of the management of patients with critical illnesses. And if we will talk about ECMO, it's not a new technique to use, but it was used mainly to support the cardiopulmonary system while doing surgeries, for example, which is cardiopulmonary bypass machine. But for prolonged cardiopulmonary support, they call it an ECMO or ECLS, which is extracorporeal life support. They use a device to temporarily support the heart and the lung when the heart or lung is failing. So if the heart is not working or the lung is stopped working, they will use the ECMO as a temporary artificial heart or lung, so that they will give more time for the management and the treatment for the main problem. When we start to see ECMO in our ICU, we used to exclude those patients from physiotherapy treatment or also the intervention evaluation, because we thought that this patient is highly critical. Let give some time for management and healing, then we will interfere. But in February 2016, our consultant, he come and ask us to mobilize a patient or to try to do something with the cystic fibrosis patient. He was 16 years old and he was conscious on ECMO. He was the first patient conscious on ECMO. So from that day, we started to read and to do some discussions, and later on we attend lectures and workshops to improve our management for ECMO patients. So what is ECMO? ECMO is extracorporeal membrane oxygenation machine. It is a life-saving technique to manage refractory cardiopulmonary failure. It's used and the usage and indication is continue to increase. It's now seen as a treatment for cardiac arrest in certain countries, allowing for treatment of the underlying causes of arrest while circulation and oxygenation are supported by the machine. There's two types actually for ECMO, either VA, which is veno-arterial ECMO, or veno-venous ECMO. Mainly the veno-arterial ECMO, they will use it for heart failure patients when the heart is failing. But VV ECMO is when the respiratory system is failing. And nowadays there is a special forms of ECMO support in which an additional cannula or limb will be added to the circuit, but we don't have to discuss it now, which will allow more support for certain patients. The ECMO circuit has a console, membrane oxygenator, the oxygen blender, which allow which will be connected actually to the oxygen and allow the oxygen to enter the bloodstream and to wash out the CO2, the pump, which will pump the blood, and the cannula. What is the indication of ECMO? ECMO will be used for acute severe heart or lung failure with high mortality risk despite the optimal conventional therapy, such as ARDS patients, hypoxic or hypercapnic respiratory failure, refractory cardiogenic shock, severe pneumonia, pulmonary contusion, smoke inhalation, and bronchial asthma exacerbation. Other elective indications are to support the heart and lung function during temporary non-functioning, such as operations or, for example, trachea or mediastinum surgeries. What is contraindication for ECMO? Actually, the most contraindication are relative. We have to balance, or the ECMO team, the ECMO doctors, they have to balance the risk and benefits of ECMO in order to take the decision of inserting ECMO. What is the complication of ECMO? hemorrhage, because the patient should be on anticoagulation therapy, infection, thrombus formation, embolic events or limb ischemia, circuit or pump failure, cannula displacement, or malposition. Do you think physiotherapy can help in ECMO patients? Let's go through some literature. Here we have a study in 2012 in University of Alabama. 16 years old female cystic fibrosis patients. They tried with her airway clearance technique, manual therapy, exercise like standing, edge, and sitting on a chair. And they found it was feasible and safe. And also in Korea, they reviewed experience of physiotherapists, including active mobilization for a patient on ECMO in terms of technical feasibility and safety. And they found that it is feasible and safe and there's no adverse effect. Only 3 sessions stopped due to tachycardia and tachypnea, and that's it. Here also we have a study in, I think, 2018, yes. Also, they want to test the feasibility and safety of early physiotherapy management. They reviewed medical records for a physical therapy, perfusionist, and intensivist to obtain the number and the type of physical therapy interventions and discharge status. And they found that by highly trained multidisciplinary team, it was feasible and safe to deliver a rehabilitation for a patient with extracorporeal membrane oxygenation. In Qatar also, they followed progressive mobility guidelines, and it was achievable and feasible. So, before talking about physiotherapy role, let's compare. When the patient, ECMO patient, actually are very sick to decide to put them on ECMO. For example, and most of our patients, they are ARDS patient. When the ARDS patient will reach this stage, the patient will be with bad chest X-ray, so the gas exchange is affected. The patient will have bad ABGs. They will be on deep sedation, muscle relaxant, and maybe on high PEEP. And also they may require high inotropic support. So this patient, when we come and evaluate this patient, nothing can do with them. Even the manual technique will be very risky. So the patient will be a long time sedated, on bed, no movement, nothing. Maybe you can just maintain the joint range of motion by passive movement, that's it. So ECMO patient, immediately they can, if he is stable, they can wean him from sedation, and he can move and do some active exercise while he is on ECMO. So when we will compare ECMO, it will help us to progress in the mobility because the patient on a machine that can control the gas exchange. So if there's any problem in patient without ECMO, I cannot do anything to ask the lung to give me more oxygen because the lung is bad. But with ECMO, we can play with ECMO parameters also to allow them and to let them be fit for exercising. So what is our main goal? Why do we have to treat those patients in this critical stage? Why we shouldn't wait for them to recover, and we'll start later on while after removing ECMO? Because physiotherapy in this stage is not only to maintaining the muscle length or the range of motion. No, it will help in recovery because it will optimize the oxygen transport and the function of the transport system. And it will reduce the multi-system complication and maximize the functional recovery and minimize the diffuse atrophy. So by moving the patient early and by preventing the weakness, you will reduce the demand of the heart. So the muscle can will not enter in the weakness stage. And if it is weak, you have the ECMO to increase the oxygenation in order to make them fit for mobilization. So what is our aim? To improve the respiratory function and promote weaning, diminish the side effect of the bed rest, and prevent muscle shortening and contracture, early mobilization and improve core stability, minimize ICU-acquired weakness, maintain and achieve a pre-admission level, assess the patient to be independent or need least amount of care before going to the wards, minimize ICU psychosis and enhance physical and psychological well-being, and reduce ICU stay. And later on, for sure, the hospital length of stay also will be reduced. So what we need as a physiotherapist to know to handle an ICU or ECMO patient, we need a basic cardiopulmonary pathologies, pathophysiology, and complication of bed rest and deconditioning, common ICU medication, ventilator and respiratory equipment, all monitoring equipment, the role of other ICU team members, and emergency procedures. So before treating a patient, we have to evaluate and we have to screen. What do we have to check? We have to check the cardiovascular parameters, sedation level, inotropic support, ECMO circuit and parameters, the mode of ventilation, the coagulation profile, the ABGs, the chest X-ray, the cough, sputum, underlying pathologies, and contraindication to treatment, pre-admission mobility level, medical plan. And each part of screening has a reason why I have to check and how to modify our treatment according to the findings. So analysis. Now, the primary goal following the patient screening is establishing a clinical picture of the patient status involving the indication and contraindication. And we have to consider weighing benefits against risk, then to relate clinical findings to patient problems. At this stage, physiotherapists should have a clear idea of what potential problem the patient has. Regular discussion with the multidisciplinary team is necessary to obtain the optimal results. And the care plan must be modified according to the patient needs and tolerance, and according to therapeutic goal also. This will improve and enhance the results, meanwhile minimize the risk. Physiotherapy management will focus on pulmonary hygiene technique if needed, lung expansion technique, and early mobilization by using an ICU mobility guidelines. Mobilization. While mobilizing an ECMO patient, we need the ECMO team to be there. And who's the ECMO team? The physiotherapist, the nurse, and the ECMO nurse, the perfusionist, and the intensivist. We have to know each member and the role of each member. Physiotherapist should lead the team, should screen from early morning and check and decide to start the mobilization session. We should focus on the movement, on the patient movement, and monitor the vitals. The nurse should scan for the lines, the tubes, drains, and the environment of the patient, like usually with other patients, and monitor also vital signs. ECMO nurse should focus on circuit check before starting the mobilization and the stabilization of cannula during the mobilization. So nothing to do with patient, only to check the cannula because it's very risky to keep cannula unsafe. Monitors the circuit integrity and blood flow during the mobilization. The perfusionist will be on the side of the ECMO machine and for monitoring, and maybe during the mobilization we have to increase the parameters of ECMO while mobilizing patients and if anything happens. Intensivists should be there also for any emergency, not only for emergency, if we need some modification during the treatment. For example, the patient blood pressure shoots up and we don't want to stop the treatment. We will hold and talk to the intensivist to suggest something to control the high BP. And if there is a mechanical ventilator while moving, we need a respiratory therapist to be with us. Possible complication: hypoxemia, tachypnea, low flow alarm, ECMO earthquake, in which the ECMO cannula will shake for a certain problem. Actually, I cannot mention them all now. Vital instability and accidental decannulation. Each problem has a solution or a certain strategy to do before deciding to hold the treatment. Let's take an example, tachypnea. If a patient became tachypnic while mobilization, we shouldn't hold the mobilization. Actually, we will allow for a certain level, which is mainly as we are following, like if patient reach 40, respiratory rate 40, we have to hold and think about supporting the respiratory system, either by increasing ECMO flow or by increasing the ventilator support in order to make them calm and to reduce the tachypnea to continue the mobilization. And other problems has, as I said, a certain solution before deciding to stop. And sure, we have to discuss this with the multidisciplinary team. And we will not increase the mobility level if the patient is hemodynamically unstable or because the patient is deeply sedated. Even after discussion with the doctors about weaning from sedation today for mobilization session, if the last decision was the patient should be sedated, for sure will not increase the mobility level. If the patient has respiratory instability, even we did all the management we talked about earlier. And if the patient is agitated, and he should be really agitated. I like to test agitation myself while going inside, because sometimes agitation can be maintained by or can be solved by talking to the patient and position him nicely. And sometimes language barrier will show that the patient has agitation. So if you check yourself that the patient is really agitated, he's not calm, it's not safe to mobilize, then we will not increase the mobility level because it will be risky. Mobilization, we can start on the bed only. If the patient is not fit still for out of bed mobilization, we can start with active exercise on bed. We can start with a cardiac chair position, because upright position, it is really helpful, has so many benefits, and it needs a separate lecture to talk about upright position. Mainly it will improve the respiratory muscle strength. It will improve the orientation also. Also, we can connect the patient on Motomed, whether passive or active. We can give some respiratory muscle training exercise also. We can give the patient bridging exercise, upper limb, lower limb exercise, and so on. Then we'll go to the edge of bed. Also, at the edge of the bed, we can give some exercise, mainly the anti-gravity muscle exercise also. Then standing. For standing, especially first time of standing, we should be very careful because even the patient is moving on bed, moving upper limbs and lower limbs, it doesn't mean that he's ready to stand. Usually we will test standing and check the anti-gravity muscle by doing bridging. So that's why first time of standing, we need the full team to be there, and we need extra support to support the knee, to lock the knee while standing, and to check whether the patient can initiate and hold himself in a standing position. Some patient will stuck to edge of the bed, and we cannot progress due to weakness. So we will choose a tilting table, because tilting table can give me weight bearing exercise, and I can do so many things on tilting table. I can work with head control, trunk control. I can give upper limb exercises. I can loosen the straps and and work and work with other muscles. Sorry, 1 minute. Yes. Okay. Here we can put patient on a chair. We can also continue doing exercise on the chair. We can start sit to stand exercise again on the chair position. Here, as I said, the tilting table. Yeah, walking with ECMO also, it's not easy, but it is achievable. We can make them to walk. We can make the ECMO machine portable, and by gathering all the team and assigning the responsibilities. And also we have to imagine the way of walking, how the patient will walk, so we can adjust line according to the walking path. In Adan Hospital, we treated 37 patients in 2017, and 2018, 55 patients, and in October till 2019, 67 patients. Actually, most of them, around 70%, they received sessions. The rest of them, they were unstable for physiotherapy session. And if you can see, most of patients, they participate in active therapy rather than only passive. And we're up to edge of bed and standing and ambulation, even with femoral cannula. And some patients, they walked and stand even with ECMO line. even it was femoral lines. The barriers, we found that deep sedation, because it will prevent us from doing the active therapy. So to solve this problem, we will perform routine assessment of sedation and pain and target light sedation by discussing this issue with the multidisciplinary team. Hemodynamic instability, we have to follow stepwise approach to mobilization and delayed screening and treatment, because difficulty to gather the ECMO team to gather all of them together in the same time. So what we'll do early screening, and we'll set a time. I'll come to the doctor. For example, excuse me, today we'll mobilize this patient by 9 o'clock. It's okay, are you ready? Are you free? And we'll talk to the nurse, the ECMO nurse, and perfusionist. So it will be easy. The pre-admission level, some patients, they cannot walk before coming to the ICU or admission. So we cannot reach more with them. And obesity also, especially if the obese patient has a long time of sedation, we will find difficulty to regain the muscle power later on. So as a summary, physiotherapy should be considered as a cornerstone in the comprehensive management of critical ill patients. And the most important skill for a physiotherapist to develop in ICU is to recognize when to initiate, when to delay, progress, and terminate the treatment. We should also weigh benefits and risk, and we should work as a team in the ICU, and continued training and education is important to improve the skills and the outcomes. Thank you.
Thank you so much, Dr. Alaa. Now we are going to be calling on, please do your virtual raise of hands so we can give chance for anyone who might want to ask questions. But I'm going to take this opportunity to, because there's one question from Marwan Hatem. I'll just search for you. So you'll be the first one. Marwan, wait.
Marwan?
Marwan asked, now, Marwan, I sent you his request. Did you see the question?
Yeah, which is talking about the femoral fracture.
Yes.
What would I do if the patient has a femoral fracture? Would I give him only upper limb exercises? Yes, usually if the patient has a fracture, we used to wait for or talk to the orthopedic team, the doctors, to give us clearance. So if they allow, for example, only sitting on the bed, let's say 40 degrees, so we'll do the rest of exercises on the bed. Because if you have any restriction of moving the patient out of the bed, you have alternative, which is more active to save the muscle power, and will not increase the demand of the heart if we went into weakness. So yes, I can give more upper limb exercise, and daily I'll check with the ortho doctors when to allow us to go more and progress on mobility.
Doctor, she has a second question. Oh, yeah, I think it was answered already. Anyone else has a question, please?
Hello.
I have a question, Doctor. I didn't see anyone raising the virtual hand. Dr. Alaa, I have a question. Have you experienced during your treatment any instance where there was a deterioration of the patient, either temporarily or that came later, that can be attributed and directly caused by mobilization on ECMO?
Sorry, I didn't get your question. Do you mean if we have any problem while mobilizing a patient? If we found any?
Yes, doctor. And after, like example, the precautions that you have mentioned, or the complications like the saturation. Have you ever encountered it? And if so, is it frequent? Is it very rare?
Sure. Desaturation mainly is the most thing. Desaturation and tachypnea. This is the main problems. But we will hold, as I said, we will hold the treatment and we will discuss with the team. And we have to like convince them of we want something to continue the treatment, not to hold the treatment. So we have so many options. Like if the patient has desaturation, we can increase the flow or the sweep flow. Sorry, I am mentioning the parameters like this because we have to have another session for training on ECMO and ECMO parameters. But we can play with the ECMO parameters. We can play with the oxygenation, which is ventilator parameters also, to allow the patients to keep him stable for the treatment. And also the tachypnea, as I said, even the parameters also will improve the tachypnea. Hemorrhage or bleeding, maybe from cannula site, and it is not something it's not a big deal. They can fix it before the session also. Double check the circuit can prevent the problem also that can happen, as I mentioned. This is mainly. But thanks God, the accidental decannulation, which is the major problem, never happened in our setting.
Thank you, Doctor. I'll call in Asma Hassani. She's raising her hand. Sorry.
Asma. Okay.
Yes.
Hello, can you hear me?
Yes.
Yeah, okay. Yeah, I have a question actually regarding pediatrics. Is there an age criteria for the ECMO?
Actually, in our setting, we treated adult patients, but we had only one pediatric patient, which she was a COVID patient. But I think she was maybe 8 years old patient. And because we didn't find any difference, but the dealing with pediatric, that's it.
So do you think it's as applicable like for smaller ages, for maybe a special need with cerebral palsy? Because many of them has problems with the also, like similar to pulmonary issues, and so I'm wondering.
Sorry, I didn't get your question. Do you mean the mobilization of those patients or ECMO, the choosing of ECMO?
Yeah, what if they need? I mean, some of them, I had patients, they were admitted to ICU, and we had patients with epilepsies, they had problems. I don't know how, if ECMO is going to be applicable for them if they need it. I'm wondering.
Actually, this decision should be taken by I think the pediatric team or the ECMO pediatric team, because as I saw before, they have to try all the conventional therapies. If it's not applicable, they will choose ECMO, or sometimes they will choose it earlier according to certain criteria, which they have to decide and compare.
Thank you.
You're welcome.
Thank you. Dr. Alaa, I'll ask questions from the people who sent private messages. Noura was asking if this is done in Adan only or in other hospitals also.
No, actually, other hospitals started. Jaber Hospital, Amiri Hospital, and recently Jahra Hospital, they have patients with ECMO. And they are mobilizing patients with ECMO.
Next question is from Abdullah Bagazi. He was asking about the femoral line. Is it safe to make patient on sitting position? I think you have covered it.
Femoral line
is
safe.
It safe to make patient?
Actually, it's safe. But the only thing that we have to check the ECMO parameters while mobilizing patient on femoral. But sitting position, maybe we will try as much as possible to reduce the angle, the hip angle in sitting, like to make the patient support the back with pillows or with any kind of support. And by checking the parameters, especially the negative pressure on the ECMO machine, it will show that whether it's safe or no. And the perfusionists also will be assigned to check for these things.
One last question from Alaa regarding chest physical therapy. If the patient is on ECMO, does she need airway clearance? Is there contraindication for any other contraindication for practicing chest PT, or it will depend on the parameters? And she meant the vital sign. Sorry, I was just reading.
This is a great question, actually. Patient with ECMO, if they need a chest physiotherapy, we can. It is applicable, but we have to let's say be very gentle and avoid repetitive cough, because sometimes cough can change the pressures in ECMO lines, and we suggest to avoid some compression on the ECMO side, on the ECMO cannula side. That's it, but it's applicable, and if needed, we can use it.
Good, thank you. I don't see any other questions. I think it's clear. There was one.
I think there's one question with Mariam. Mariam Anwar. How long we can give patient sessions in ECMO? Yeah, it depends on the patient. If you mean per day, we can give 2 sessions per day. It's up to the need of the rehabilitation and session. And how long you mean by days? We can continue till they are decannulated from ECMO. If you mean this, the number of sessions.
Okay. One more question from Sarah Al-Dalama. If a patient is on a VV ECMO and the parameters are high, but the patient is extubated and doing fine vitally, but the only thing is that the patient is tachypnic during exercise, what does that mean, and how can we improve this to proceed?
If the patient on VV ECMO, high parameters, you mean high parameters of ECMO, but the patient is extubated, doing fine, vital stable, the patient's tachypnic. Yeah, tachypnea, we can increase the, as I said, the parameters, but if the parameters is already high and the patient, we have to check the work of breathing. If the work of breathing is fine, we can do gentle exercise and we can break down the activities and not allowing the patients to have a high work of breathing, just to maintain.
I think that's it. No more further questions. We would like to take this opportunity to thank you, Dr. Alaa, and thank you everyone for those who have attended today's lecture. We look forward to seeing you soon next week and in the coming weeks because we have plenty of lectures planned and scheduled. And again, from the bottom of our hearts, thank you, Dr. Alaa, for today's wonderful lecture. Good day, everyone.
Thank you so much.
Good day, everyone.
Thank you so much.
Bye-bye.
Bye-bye.